I told someone this morning my executive assistant gives me an address and a slide deck and says go there. So I might even address the slides today. I mean, who knows? We'll see. Secondly, you can see, well, actually, my professor of cardiology at National Naval Medical Center had as his patient Congressman Claude Pepper from Florida. And Claude Pepper was very interested in care of the aged. And one of the sayings that my mentor, Bill Baker, passed on to me from Claude Pepper was, as people get older, we get more and more like ourselves. So that's an introduction to my title up there. So I just run around poking people in the eye, I think. So anyway, I guess you all will have to get used to that, or kick me out, or vote me off the island or something. But let's see, do I do this?
I think so. I'm happy to do that if you'd like.
Yeah, can you do that? That'd be great.
We found something for Ken to do. That's
Task I can handle. Whoa.
At least I'll say next every now and then. So anyway, I'm really not going to talk very much about tools, and hopefully I'm going to cover maybe some stuff that might be related to the conversations that took place this morning about why bother. It's sort of where I'm going to go with this, but let's go on. So that's just you can keep going. So. And I'm going to cover all of those things in some way, shape, or form. So let's go to the next slide. And generally, the logic in my head is kind of to go through that cascade to ultimately get down to some set of solutions that offer somebody something useful. That's sort of the idea. And I did number 5 that way on purpose. You'll see why in a minute. That in order to, it's my humble attempt to encourage you when you think about modeling or solutions and all that, to deal with real people, not end users, not patients, not necessarily veterans, just people trying to do something in their lives. And you'll see as I go through this that there's some a little bit of literature on that point that I would encourage you all to pay attention to. And by the way, let me stop for a minute now that I mentioned veterans and ask maybe just a show of hands, how many veterans in the room? A few. Well, anyway, thanks for your service to the country. So great. So let's go. And I might say, I don't know how some of you who have a company affiliation also. I'm sure many of you in the room. Well, I guess we can ask how many of you are from a company, a private company, public company, commercial company. Anybody? One. It must be more, right? Okay, so that's fine. Thanks. So I would suggest also in dealing with people, I'm sure many of you who just raised your hand have veterans as employees of your companies. And where you want to get sort of a glimpse of where you might add value, I would suggest you all think about treating your own employees as a veteran focus group and getting them together and start peppering them with questions as to what might be relevant, because that group would know both best what veterans need and what your company offers, and try to do the intersection of those two things. So let's go to the next slide. So this is the first bit of literature I wanted to share with you all. Marty Kagan, his shtick in life is product development in a commercial sense. He doesn't talk about enterprises or all this hoo-ha bureaucratic blah, blah, blah that people like me say, but it's how to get stuff in front of people that they will actually find useful. And let's go to the next slide. And those are his 3 criteria. So somebody mentioned something about criteria this morning. And you might actually, I don't know whether this makes sense or doesn't make sense, but you actually might want to think of the products and tools and all the stuff you all are talking about here to do model-driven software development, model-driven systems engineering, all that. You might think of those as products. And think about what Marty Kagan has to say about making a product valuable, usable, and feasible. And if any product doesn't have those 3 characteristics, it will fail. Any one of them is not enough. 2 of them is not enough. It's got to have all 3. So figuring out who your target audience is, who exactly is going to use these things, under what circumstances. And by the way, you'll see in a minute. Let's go to the next slide. Well, I mentioned the person, so I'll come to the by the way in a minute. But I mentioned the person a few minutes ago. One of Marty's shticks beliefs is actually observe people trying to do something, and observe them trying to do something that really angers them, frustrates them, slows them down, gets them upset, wants to go to court and sue somebody, whatever it is, that's likely to be the area where the next value add opportunity is, right? And that's how he approaches the first of those bullets, value, and how to identify the search. So who's your target audience for these tools? Is it developers? Is it systems engineers? Is it architects? Is it the CEO, the CFO, the CIO? Who is it? And maybe the better way to get some traction with model-based off systems engineering is to segment the market and figure out who exactly it is you intend to go use those tools, and watch what they do on a daily basis and try to figure out, well, can these tools be shaped in a way to help what I'm seeing that guy struggle with or that person struggle with? And next slide. So this is the next one, Eric Rees, and he has a bunch of very similar things to say. I was going to tell you, oh, by the way, a minute ago, I would also encourage all of you to, if you don't know Walter Isaacson, he wrote a book and then some articles in Harvard Business Review about Steve Jobs. And one thing Steve Jobs says is, I never asked the customer once what they needed, ever, right? And yet, of course, he managed to put something out there that most of us have some form, way, shape, or form to use. He says the same thing. And in a sense, Marty says the same thing too. You don't go ask, you watch. Because if you ask, you know, in all this alphabet soup that you all said this morning, I can guarantee you, and someone was talking about language this morning, and physician language and all that this morning, right? It's the same thing. I mean, imagine the world before smartphones, right? And you are the guy that wants to invent a smartphone, and you walk up to you and say, what do you want your smartphone to do? And they're going to look at you like you're crazy. Say, what is a smartphone? I don't know. Well, what do you mean, what do I want my smartphone to do? So same thing here. I mean, you know, what do I want my modeling and simulation and my sys UML to do? They're going to look at you and say, I don't want it to do anything. I don't know what you're talking about. Go away. Anyway, he says that too. Watch people, watch what they're doing, and you know, segment your market so you know who you're watching, and presumably you're going to develop something that's useful for that population or that's representative of that population. Next. There you go, without asking. So we covered that. Let's go, and well, let me stop there. So what both of them also allude to is prototyping. And I was just talking to Raj earlier about modeling and simulation. They would do that through prototyping, and prototype. And if you look at them, I'm going to dream a percentage up here. I don't know that it's exactly what they say, but something like 80% of the effort in putting something out into production use, into the market, in their view, should go into prototyping, to understanding the design. Then you take all the code underneath that operational prototype, throw it away, give it to the engineers. There's another 20% of effort to make an industrial strength, and you're done. But it's not the other way around, and you don't build the back end first, and all that kind of stuff. And the engineering elegance of it is irrelevant. So next. And they're everywhere. I just mentioned on number one up there, they might be entrepreneurs, might not be entrepreneurs, but I mentioned to all of you who have veterans on your staff, right? Go talk to them, use them this way. See if you can't give them an opportunity to think outside the box and help you with what your own go-to-market strategy is. And then he steps through these validated learning and all that. In Eric's view, validated learning means you go through some scientific method, and for the clinicians in the room, it very much approximates what a clinical trial would be. When you set out to design up front what you want this pilot to teach you, and then you set about executing the pilot, and then you capture all the lessons learned out of that. You don't just go pilot and fail and say, well, therefore I got a bunch of lessons learned. Not that way. Set up your hypotheses first, do your pilot, and then validate or negate your hypotheses. So next. And then you can go next, that's fine. The innovation accounting is simply that we've got to find a new language to deal with our CFOs, our resource sponsors, and all that kind of stuff to say that, yes, we're doing piloting. No, this is not going to production yet. But, oh, by the way, here are the things I plan to learn. Here are the things that I have learned so far. They're all in accordance with the plan. So that's the way I'm going to account for my effort. It's a new accounting methodology that he's recommending. And all of it has to do with shortening this cycle time. So on that spin around. Let's go next. I'm going to get a little bit more specific here. So again, you notice this enterprise view, though, they're both focused on product development, right? So it could be this, whatever this little thing is, and putting this thing out in the market. The term enterprise doesn't mean anything to these two guys. But if you step back from that and layer on top of that your own reading of, let's say, the VA strategic plan, or a bunch of GAO reports on VA, or a bunch of IG reports on the VA, or the Washington Post reports on the VA, you yourselves can get a sense of what the enterprise, or listen to Bob McDonald speak. You all can get a sense of what the enterprise priorities are. Layer that on top of everything then Marty and Eric say. So you can use that to sort of pick your opportunities. Well, based on what Bob McDonald is saying, do we really want to go observe janitors sweeping the floor? Well, maybe not. Maybe that doesn't map directly to Bob McDonald's strategic objectives, right? But if you want to go observe clinic coordinators and what they have to struggle with, well, maybe that does map to something that Bob McDonald says is important. So you can layer the two together, even though Marty and Eric don't address this enterprise view. But the second one is their industry develops and deploys systems based on handcrafted code. Most do not take advantage of model-driven software, blah, blah, blah. This, I think, is from Gartner. Well, and I'm going to stop there on this slide. The rest of the stuff you can read yourself on this slide, but what I put in there is why not? And my humble opinion from listening to you all today and from my experience is, is that by and large, and you heard it this morning about physicians, by and large, the audience you ultimately want to get enamored of your approach, they don't give a goddamn about process modeling. So it doesn't matter how good you make your tools if they don't care about process modeling, right? It's like selling business process reengineering to a symphony orchestra. That's probably not going to work very well. And if your audience thinks of themselves as a symphony orchestra, they're not going to business process model the damn thing. They're going to go home and practice the saxophone. So you made business process modeling selling tickets to the symphony orchestra, but you wouldn't go to the members of the orchestra for that.
Does it matter that the symphony doesn't have a saxophone?
Good. I don't know. But anyway, what I'm in this I find myself saying to lots of people in industry who come to meet with me. And by the way, I try to meet with many people from industry. I try to meet 1 or 2 a week, and I've done that for my entire career in IT. By the way, that's since 1982. So that's a lot of industry I've met with. Mm-hmm. And by and large, they come in with really smart, nifty ideas, much smarter than anything we in government could dream up, right? But the problem they miss is they keep trying to make their product better and better and better and keep missing, and therefore treat this interaction as a sales opportunity instead of backing up and saying, now wait a minute, this is actually a marketing problem I have here, and I haven't put enough energy into shaping the market yet, so my problem with that customer is they don't know why my product or my competitor's product is even worthwhile. It has nothing to do with the feature set of my product. Zero. And the same thing here with process modeling. If we can't get process modeling to be of value in healthcare delivery, what difference does it make if we go to SysUML? It doesn't matter. The feature set is irrelevant. Let's go to the next slide. So number 9 there, I want to point that out to everybody here because at some point in time it should become relevant to us, and I'm giving you all some of the secret sauce here, right, that might help you all get across why is model-based systems engineering important. And by the way, based on the conversation we just had, by the way, he and I can give you examples of, forget the model-based systems engineering, he and I can give you examples of where systems engineering itself, as expertise, deteriorated in the Department of Defense from 1990 to, well, from mid-1990s to 2000, the systems engineering expertise evaporated. It moved backwards. So let alone modeling and simulation on top of it. So we have 2 examples which we can share with you all later about where that, where the evidence of that is still present today. Anyway, number 9 there though, I want to also get across the industry, which is, despite the fact that we are seen to be in government genetically incapable today of any form of systems engineering or systems integration, we now, despite that, are moving forward and saying we're going to go into service-oriented architecture. And therefore, not only were we lousy at systems integration before, now we're going to have hundreds of piece parts to integrate together. And somehow or other, we have deluded ourselves and probably deluded you into believing we could actually do that. So I would say without some form of model-based systems engineering laid on top of our probably overly optimistic aspirations, I would say we don't have a prayer of doing what number 9 says. So hint, hint, hint to you all, try to think about that and you go to market strategy as to why we would want to do model-based systems engineering. Because we're professing to do number 9 there. And I'll go one step further with the electronic health records. And why do we think number 9 is important? It's because of the economic drivers behind commercial off-the-shelf products for electronic health records. And those economic drivers are such that the commercial industry has to sell those to the healthcare entities, right? Well, if the healthcare entities to whom they are selling are just at the very beginning of drug-drug interaction checking, or they're just at the very beginning of any form of alerted, automated alerts and reminders for their healthcare providers, they're just at the beginning of that. That industry, with that business model, with those products, is going to come to the VA and be dead on arrival, right? Because we've been doing drug-drug interaction checking for 20 years already. So that is totally non-viable. So from our perspective, the business model, the feature set, and the way those feature sets are incorporated into the product for a commercial off-the-shelf solution for the electronic health record, for us, to me, is an absolute non-starter. It would carry us backwards 20 years. So that's from a need perspective why we're left with number 9. Okay, next. Observe people trying to do something. Your own staff who are veterans, they're trying to submit a claim or get an appointment or whatever it is, and deal with it. And here, unfortunately, I heard someone say something very nice this morning too, which I liked, which was, this is, what did they say? It's old news, but still a problem. Julian said that, I think, something, right? Well, this is old news, but still a problem. We're still not servicing veterans the way we should be servicing veterans. And again, you might say, though, submitting a claim, asking for an appointment, appointing the patient, getting an authorization done, blah, blah, blah. That's not a symphony orchestra. That's certainly all amenable to process assessment, right? Well, you have to step back and say, well, okay, guys, why aren't you doing that? I mean, we still are not very good at taking an end-to-end look, a veteran-centric look, from end to end of what it takes, of how we VA look to a veteran. We're still not very good at that.
But don't you have subpopulations of veterans?
Absolutely. So market segmentation. So the fact of the matter is it's like suppose you all with SISH, UML, or whatever it is, it's analogous to my ear. It sounds like we're going to invent a new instrument. We're going to invent a new tool to clean every musical instrument in the symphony orchestra. Well, that probably won't work. I think we got the same thing here, right? So we have multiple generations. I don't know, you all may know better than me, maybe 5 cohorts of veterans, something like that, and what's going to work for one cohort probably isn't going to work for another cohort. Right? So yeah, I think it's very important. Anyway, so let's go to the next slide. And so there you are, the value proposition. Somehow or other, improving service or reducing spend or some combination of the two should be the value proposition. Well, one more time there. I mean, we behave as if we're, in all instances, as if we're a symphony orchestra. So what we do is we have a bunch of gurus inside of the department who sit around and say, I think these 5 things are really important for veteran service, right? But we haven't gone out to observe any veteran trying to do anything to make sure the veterans actually think those 5 things are important. So anyway, so the value proposition really largely is a figment of our imagination, of us bureaucrats. Next. How can model-based systems engineering help us? Well, again, it's that yellow line, and this thing over here, by the way, which I'll speak more of later, key performance indicators. I'll come back to that in a minute as sort of yet another level of abstraction upward. Above code and also even above business processes. I know one of the OMG mantras, I guess, is that maybe we can sort of live at the business process level and not do all of our configuration management debate and decisions at the business process level and not necessarily at the code level. Well, I would contend that going to key performance indicators, you can even go one level of abstraction above the business process, all the way up to what is it you want the outcome to be. You want the veteran to be healthier, you want the cycle time and appointments to be shorter, you want the cycle time on claims to be shorter. What is it exactly? And then cascade down to the business process, and then cascade down to the rest of what you see there, the information management, the applications, the services, and the boxes and the wires at the bottom. Today in VA, we cannot draw that yellow line. And largely the reason we can't draw the yellow line, the top of it, we're semi-decent at. This part here, this part we're semi-decent at, and I'll talk more about that. This part we're even a little bit stronger at. But the rest of this right here is kind of right there, big circle. A miracle happens. It's the middle is not filled in there, and so we can go to the next slide. So not only can we not draw one of them, of course we have multiple programs: eliminate homelessness, eliminate the claims backlog, strengthen access for veterans to health care delivery. You know, all those names you could put up on the top of those yellow lines there. In most instances, we do not have key performance indicators established for them. In most instances, right? In one we do, this evolution. I'll show you those in a minute. And that was, if anybody knows the gestational period of an elephant, I don't, but it took us something approximating the gestational period of 2 elephants to create those KPIs. So I'll show them to you in a minute, simply because it took that long. It's noteworthy. But let's keep going. So from a SOA perspective, however, we can step back around maybe the year before execution, in the year of execution, and say, well, wait a minute here. This guy needs a server, this guy needs a server, that guy needs a server, blah, blah, blah. So instead of 13 servers there, can we buy 6 that are bigger but much cheaper and get the job done better? So we can still look inside of IT from a technology strategy perspective at looking for opportunities for common services down there across all these programs. And then from an accounting perspective, however, we wind up with an allocation process where the cost of that thing has to get allocated across there, and that will tell us what the cost of that yellow line is in order to achieve that key performance indicator. It also tells us if this box fails, or if these 3 boxes fail down here. If these 3 fail, it also tells us what outcome we're not going to get. But we're not quite there yet. So let's go next. And next, same thing, common services at the application layer, a comprehensive, holistic approach to data management where we actually organize data based on what's good for a veteran, not what's good for VA. Next. Same kind of notion there. Let's go next. So we're starting now. Our first opportunity is fiscal year 17 through 21, so we're starting to try to build our budget this way. So you can think of each one of these columns as being a yellow line, if you want to look at it that way. Up here at the top, the key performance indicators. Here's all the business processes and stuff that would be in there. Here are the service level agreements that would be established that are compatible with those work processes. And here would be the IT bucks necessary to enable that down at the bottom level, the software, the hardware, the capacity, blah, blah, the COOP DR, et cetera, et cetera. And again, if this investment is, and so the art form here is now this whole thing gets the same priority. Same priorities attached to that whole column, and we'll put the budget together going forward. That's not the way it is now, but that's our intent as to how we want to do that. Let's go to the next slide. So let's go into healthcare a little bit and understanding your audience. I would strongly recommend this book to people who want to understand the underpinnings of why physicians behave the way they do. I don't remember exactly the year that it was published, maybe in the 70s or 80s, something like that. Pulitzer Prize winner, I think he's a sociologist. Hundreds upon hundreds of footnotes, very erudite book. And it talks about the progressive political enfranchisement of the medical profession, leading to what is today not the military-industrial complex, but in fact the medical-industrial complex. And the medical-industrial complex, we'll get to GDP in a minute. Just remember, every dollar that is earned from our dysfunctional system represents a proponent of our current dysfunctional system. So the proponents of our current dysfunctional system are very large in number and very rich and very influential, right? And none of them like business process reengineering. So what you all have to also sit back and think of in your market segmentation approach is, are we after, in whatever you want to model, are we after stabilizing change, or are we after destabilizing change? And depending on which one of those it is, your business model better be very different. Very different with respect to timeline, expectations for ROI, and when your crossover point is going to be, and all that. Next slide. So the strongest lobby in the United States, and the first lobby group in the United States in 1946 was, does anyone care to guess?
American Medical Association.
Correct, the American Medical Association. And it is because of the American Medical Association lobbying efforts with Franklin Roosevelt is why we did not have national health insurance included in Social Security legislation. And that has been the story ever since, and Paul Starr explains the entire story to you. You had two references this morning to The Economist, which I was very happy to see, my favorite magazine, I might add. And my favorite cartoon in my favorite magazine is a photograph. It's a bunch of doctors in the OR, all their gear on, masks, hats, blah, 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 surgical light shining down into the patient's abdomen, presumably, and the caption on the picture is, there must be a wallet in here somewhere. So that translates into this chart, which is, I happened to find this one in 2008, it looks like, but as you know, the story has just continued to get worse. 16% of GDP at that time, and I don't know, it might be 17 or 18 now, I don't know what the number is. I've lost track of it. It's big. Next. It's biggest in the world, by the way. Next. However, if you look at the success of that, that is, we in America have been seduced into accepting an incredibly bad value for healthcare delivery in the United States. And for the life of me, I cannot understand how particularly people in industry who for years have been healthcare buyers for their employees tolerate this incredible bad value when if you were negotiating the cost for any other input to what you produce, you'd be negotiating the hell out of it, trying to get the cost down and the value up. But yet, we all go to sleep when it comes to healthcare and tolerate that problem, which is, but for that cost, if it's not clear to you, for that cost, the U.S. should be this color, right? But we're not. We're that color. Right up there with Mexico and Syria, I think, or something. Yes.
I have a graph I can send you, published by the WHO, which plots life expectancy against healthcare expenditure as a percentage of GDP. And the US is just an outlier right up on the right of the graph.
Same message.
I'll email it to you.
Sure, absolutely, great, perfect, thank you. So I'll update my charts and thank you for it. Terrific. So there you go. Bad deal. So cis UML. So if that's your audience that's consuming 16% of GDP and giving that result, do you think those people are going to be interested in business process reengineering to somehow or other make that better? They are all enfranchised and stopping you from doing what you want to do. So if you don't come up with a market strategy that's combat-like in nature, maybe you want to build all your business plans to focus on stabilizing change, and then you'll be fine. Right? Just suck more money out of Americans' pockets, and you'll be in good shape. Next. So this is the medical literature, and this just says a bunch of stuff about how the medical literature itself frequently publishes stuff that can't actually be reproduced at the bedside. But let's go to the next one. We have a graphic here, which is even a little more interesting. We have some doctors left in the room, I guess. Physicians, anybody? No physicians? One physician. Okay, great. So this is thrombolytic therapy for acute myocardial infarction. And each one of these little lines here, these black dots are clinical trials, and those black dots are the results of the clinical trial. And if you'll notice, on this side of the chart, these were successes in those clinical trials, and those were clinical trials where the intervention failed. If you'll notice, there are no black dots on the failure side. No clinical trial of thrombolytic therapy for acute myocardial infarction failed. None of them failed to show benefit. Yet, 1960, 1990, so if you go across here around somewhere here, 1989, all the way across here, you will see 30 years after the first clinical trial showed benefit, there was still one textbook of medicine that even failed to mention it. 21 textbooks, 5, 10, 2, blah, 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 all the way down to one textbook still here. Now, presumably, that's in all textbooks. But if you were the poor schmuck who had your myocardial infarction here in 1970, and your doctor happened to read one of those textbooks of medicine, you probably didn't get thrombolytic therapy. Right? So Is that a problem you all want to fix, or is that not a problem you want to fix? Can IT fix that problem? Yeah, but it can, right? Because you can drag a lot of stuff out of the medical literature, put it into clinical decision support, and put it at the bedside at the point of decision making, right? But some end users got to want that to happen. Just because you walk in with that kind of capability and a modeling tool to say, wouldn't this be nifty? They're going to say, well, I don't know, not so much. I mean, you know, if my myocardial infarction patients have 5 complications while they're here in the hospital, quite frankly, we, the hospital, have a longer length of stay and we make more money. Now, yes, the Affordable Care Act is sort of changing that. ACOs are sort of changing that. But I ask you all again, think about where are all the social changes, socioeconomic changes in healthcare coming from? They're not coming from the AMA, right? So we want doctors to do this and we want doctors to do that. I don't know. You know, so that's another thing, market segmentation. Maybe for all this process modeling work that you all are talking about, systems engineering, maybe you need to go to the payers. In one group, I would like to point out this morning, Julian mentioned, he ran a little test on the audience here. He said, what agency is in charge of, and then to fill in the blank, what agency is in charge of quality of blah, blah, whatever it was, right? And everyone said the state this, and somebody, National Transportation Board, blah, 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 a bunch of answers, right? What question did Julian not ask? What did he not ask, right? With this cacophony of devices, the second speaker said the patients are, and the families are acutely aware of this cacophony of devices, right? What group did Julian not ask about? Does anyone want to take a guess?
Patients.
Patients, exactly. Why aren't we thinking about patient advocacy, right? I mean, the patients, if that photograph taken through that fish lens of the oxygen membrane, oxygenated hoo-ha thing, if we took that picture and showed it to a bunch of patients and say, do you want to put your daughter into that situation again? What do you think the reaction would be? Right? They would be horrified. Where is the patient advocacy? So what I'm saying is, in addition to thinking market segmentation, there's one market segment I would strongly encourage you all to think about, which is the last group that we have to get empowered to force change, and that is patients, voters, consumers, what Marty Kagan would call people. And maybe we could even fix this problem so doctors care. I mean, if doctors make as much money here as they do there, who cares what the textbook says? That's what Paul Starr would say. Next. So anyway, this new nexus of forces can help us think through some of these things and actually help us, I think, with a lot of what Marty and Eric are telling us, if we want to take advantage of those things that way. Next. So that we get down to understanding what's valuable, useful, and feasible. Next. Okay, so you know, keep your eye on the goal, right? Is what this is. So, and I mentioned that before. This could come from listening to the Secretary of VA. This kind of stuff could come from VA strategic plan. It could come from IG reports. Blah blah blah. But understanding these things and then going to do the observations would probably give people a hint as to where those observations are likely to be considered most important by whoever's going to have to implement that change. Improving access for veterans in our case, or whatever those happen to be. Next. So I told you I'd show you key performance indicators, and what key performance indicators get to is business outcomes, and you'll see in a minute where we're actually trying to step back and say, now wait a minute, we're going to spend another $700 million on this new electronic health record. What is it we actually want to achieve? Well, we want the screens to be blue instead of green. No, don't think that's good enough. Well, we want this data element up there. Yeah, man, okay. Well, we want, instead of 10 screens, we want 5 screens. So, not really. So let's go, and this is the 24 months that I'm going to show you here next. And by the way, traditional attributes of a metric. So sooner or later, we would get to that next. In terms meaningful to people. Right, and for a key performance indicator to become a metric, obviously there has to be an expected value and an actual value, actually expected, actually against expected. So let's go to the next one. Those are just some of the risk mitigators. Let's skip that. we can talk about those later. I want to get to the, and KPI should ultimately be used as a decision focused on outcome as to whether we actually roll something out across our enterprise or not. Are they achieving the objectives? The intervention, next. Same thing, next. We need metrics that are going to mature over time. Is it hard to implement KPIs? Yes. If you look at that framework for change, there could be many others. If you all like John Cotter or whoever it happens to be, framework for change, there'd be changes in each one of those dimensions that have to happen in order for these KPIs to work, right? Even down to potentially reorganizing the way a clinic floor plan. But yes, we need new policy, we need to reorganize, we need to train people, we need the IT solutions that actually capture the data so we can actually populate metrics. Leadership is going to have to make decisions on those KPIs. People are going to have to be trained on collecting the data, using the data, et cetera. So let's go to the next slide. Okay, there they are. So 24 months to get that list. And that list has now been approved by our Undersecretary of Health, but at least I think of that as the top level of your abstraction layer. What we should be doing now is saying, okay, now all the analysis of alternatives under each one of these. Will this feature set improve access to care or not improve access to care? Will these three feature sets all improve access to care? And if so, number one, by how much, number two, by how much, and number three, by how much? Right? We don't use these KPIs this way. In fact, these are brand new. So we haven't started, VA, have not started using that value proposition with respect to investment decision making yet. Right? But at least we have them now, and we can start ourselves down that pathway. Deceptively simple though they look, 24 months to get that established. Next. And that's just the textual description of each one of them. Our next phase, as I flip through those slides there, is to create the underlying metrics program, the data collection program, establish the targets and all that sort of stuff for every one of those.
Can I just let people know that the slides will be made available? I see people trying to snap pictures.
Yeah, you can have the slides if you want to wrap your dead fish in it. But anyway, and so we've all those KPIs, because they've some of them were sort of created midstream anyway, they've all been mapped back to the product roadmap for Vista 4. So as best we could do that mapping, yes, it does look like the capabilities, functions, and features of Vista 4 will in fact have something to do with bringing about the realization of those KPIs. Next. And that's just how we did the mapping. We did that for all of them, but next. Too far. So information sharing. So I just want you to focus on that subtitle up there as to why information sharing is important in our environment. And what I'm about to tell you may be irrelevant in the private sector healthcare delivery. I don't know, and I'll elaborate on that in a minute. But 79% of veterans who get care from us get some care somewhere other than the VA. Some of that paid for by the VA, some of that paid for by the veteran. But nonetheless, 79% get care somewhere else. So information sharing for us is a critical success factor. So, and so whatever, but we have data standards, tools, techniques to better understand semantics, syntax, and transport, and maybe even process if you want to go that far. But anyway, with respect to information sharing would be of great value to us. That may not be of any value to St. Elsewhere. I don't know. They might profess they're interested, but quite frankly, the David Grail model that fell apart in California is still that model that didn't work in California is basically the model we have for Indian. So why would we expect it to work for Indian? I don't know.
Can I just make one point on that slide? So what that says, I do some work at VA. So what that says is if VA gets all of its hospitals and all of its clinics 100% perfectly integrated, it solved the problem for 21% of its patients.
That's right, because that would be internal to VA only. That's right. It's got to be. We've got to go outside the VA to solve that problem. That's exactly right. Again, with a lot of partners who may or may not want to do that. I don't know. We can skip that. That's just a tutorial on information sharing. So next thing, one of the approaches we're taking here, and I'm going to focus. I put the star around that one because the slides are just an example of that one thing, but. Of how we're trying to mature ourselves to integrate business processes with IT capabilities. Now, this is also brand new. What I'm about to show you here is less than a year old, so we're just at the very beginning of starting down this pathway. What I'm about to show you, we also have nothing in healthcare like this yet, and that it's only at the very beginning in claims processing. So let's go to the next slide for centralized mail processing. So what VBA is now doing is beginning to lay out, what you see here is sort of the as-is process for handling mail, whatever it is, plan development, centralized mail. This is the as-is process. These are the IT capabilities that they want, and this is the to-be process that would be enabled by those IT capabilities. So this is a graphical depiction of what is only a few months old, and how we're thinking about trying to align organizational goals, objectives, business processes, IT capabilities, and BPR. So would that be given to some underlying modeling tools? Yeah, absolutely. And I know there's some people who are at least beginning to think this way. Yes, but let me assure you, at the very beginning, not next. So for that particular one, centralized mail, they even did a quantitative estimate of how many claims would be taken out of the claims backlog on a yearly basis by centralizing mail. So there's a little bit of attempt here to quantify the ROI, not in dollar terms, but in terms of mission impact, in something that would be meaningful to a veteran. Let's go to the next slide. And then this is some of the stuff I think you all probably already know on tools. I don't know that I need to cover all that. I guess, let me just say in general terms, it sort of speaks to, I think what Gartner's trying to speak to here is the readiness, as I was saying before, for these approaches and these kind of tools. If the organization isn't ready for them, the features and functions of the tool don't matter. And so social collaboration integral to business process as well. I mean, how many of you work in organizations or sell services to organizations where there is no collaboration across internal organizational boundaries whatsoever? I'm sure none of you have ever seen that. Anyway, what Gartner's saying is, if you can't get the organization past that, you might as well not walk in the front door with a modeling tool. Unless you're after stabilizing change, where you want to, in fact, strengthen the walls of the silo and use your process modeling so that no one ever communicates with anybody else outside the silo. I guess then you could disregard this slide.
That's not your game plan, is that? If that's not your game plan, is to strengthen the silos?
Well, not my game plan. What's your game plan? Next. So I put this up here because I thought this was interesting about processes and Marty Kagan stuff and Eric Rees and how to go about actually observing people doing something. Look what they say about if you simply look at process modeling as an opportunity for stabilizing change. If you simply look at it as an opportunity for stabilizing change, according to Gartner, there would even be a lot of businesses that would no longer appreciate that mindset because they want to do the next new big destructive thing. And if you're not prepared to help them do the next new big destructive thing, don't show up. And it's interesting that it's now a coin toss because business process reengineering can be either stabilizing or right. If you want to make the Tasty Diner more efficient so Tasty Diner never goes out of business, you can do a little BPR on Tasty Diner and you wind up with some more Tasty Diners. I mean, you're not going to go to the fast food industry from that. That won't happen, right? So anyway, what they're saying here is pretty quickly, Lean Six Sigma expertise is going to become a liability, right? Because it can easily be misused to create nothing more than stabilizing change. Next. All those devices that we saw the pictures of this morning, the device cacophony. If we unify, let's say, we unify all the displays, the digital displays, we can tell which beeper is going off, blah, 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 blah. We get them all integrated together, the information is shared amongst all of them. And because of that, and because of the flaws in the medical literature, the percentage of patients now gets even larger who are doing membrane oxygenation therapy, right? It goes higher. But if we don't have the substantiation in the medical literature that's really necessary, all we've done is build stabilizing change. So we'll have, now it can go from whatever the number of devices was, 30 devices to 40 devices in the operating room, and give the medical industrial apparatus opportunity to charge yet more. For what value proposition? Let's see. Okay, so the starting point is not process nor information, it's people and technology. I mean, that sort of goes back to what Marty Kagan and Eric Rice were saying. Watch people frustrated trying to accomplish something and link that to enterprise goals, and then link that back to making your own decision about are we out for stabilizing or destabilizing change. Let's go to the next slide. And this slide is sort of the Nike slide. It says just go do it. I mean, you know, if you prepare too long, you miss the boat already. I mean, the idea is not to sit back and keep preparing. The idea is go engage with people who are frustrated trying to do something and start building products. Get them out there. Fix a problem. It's a real problem. Next. And I think this is sort of exploit. I'm going to skip the tool stuff. Next. Is there another slide? So this is our frame of reference for information interoperability. Again, we certainly would like to learn more about what OMG is doing in that regard. I think you have some standards moving forward there. As we look at information interoperability now, we kind of use this as a punch list to say all of these considerations have to be addressed. And in order for a sender and a receiver to actually understand the same thing with respect to information. That IEEE definition that we all saw earlier is one we've used quite a bit as well on information sharing, getting a sending and receiving system to understand the same thing and be able to react to it. What's conspicuously absent from that definition is there's no human in that loop, the way IEEE defined that, which we believe is our goal for information interoperability as well. Anyway, we can go to the next slide. So, yeah, and that's sort of our umbrella level architecture as to how we're trying to integrate our piece parts together, really with sort of a unified back end, and mobile is simply one more set of devices really by which you do your business. I mean, it's not really a unique solution per se. Next. And let's keep going. The definition of tools and why tools are useful. I think this is sort of OMG gospel as to why we want to get to model-driven systems engineering and using these tools so we can orchestrate our activities at the business process level, or I'd say even higher at the KPI level. Next. Same, let's keep going. Next. And we can skip that. Next. And then this is just stuff from OMG next. And these are the words from OMG that say why model-driven architecture is a useful thing to try to live higher up on that value chain. Next. And if you want to know where we are in VA with respect to architecture today, I think both of these should be public-facing websites, which I think you can get to. And for better or for worse, I mean, feel free to read it. And if you want to give us comments on what we missed, that would be great. Next. That's it.
Philip was kind enough to give up a few moments, so we have just a couple of minutes for maybe a couple of questions.
Sure.
Does anyone have any questions?
I'm going to stick around after you, by the way. I'm going to be on this panel this afternoon. Yes.
There are places in the country that seem to have a preponderance of veterans, and they have hospitals that they may go to, and maybe it's down in Florida or Norfolk or I don't know. I saw clusters of this.
Yes.
And so couldn't they be the focus instead of trying to get every hospital and every clinic interoperable, to just work on some regional approaches?
Sure.
And so it's not quite the David Brailer approach, because I don't think you're going to have spread it everywhere. But aren't there places you could get?
Sure.
Like in the state of Maryland, CRISP is not bad. New England's pretty good.
Yeah, and which the geographic dispersion you describe is correct. I guess the sort of, and there are lots of local sharing agreements, by the way. A lot of VA medical centers do their own local sharing agreements with somebody down the street for something. I mean, it could be, some of it could be information sharing, but more likely it's actually for sharing of healthcare services.
Right.
Anyway, so a lot of local agreements happen. I guess what I would say is, though, if we're after that IEEE definition of semantic, syntax, and transport, right? Once you figure all that out at the local level, you figured it out for the national level. So I'm not sure going local reduces that the challenge of semantics and syntax harmonization.
Yeah.
It's the same challenge for the interoperability purpose.
Yeah.
There might be a lot of other reasons we want to try local things like that, experiments and whatnot. Sure, usability experiments with respect to the staff there, or the veterans themselves, or some new appearance of blue button that we want to see if it's actually works. Sure, I mean those kind of little local things would be very useful. I think the way Marty and Eric would recommend. Absolutely.
Thanks for the context, and the first step toward improvement is awareness, and it's clear that you're talking a lot about awareness of the problem and ways to improve it. what are some tangible examples of what the VA is doing to just do it? You know, you for instance, you detailed some of the KPIs. How is the VA going to get to those KPIs and be able to,
Well, those
to
are
present them?
two separate questions. So on the just do it side, I think the best thing would be for me to give you a historical example. There was something called the Government Computer-Based Patient Record Initiative 15 years ago, something, GCPR, I don't remember, a long time ago. And then the stated objective was already to have sending and receiving computers understand the same thing with respect to information, shared information. We tried and failed. So finally, the just do it notion is the CIO of the Military Health System, the CIO of the Indian Health Service, and at the time the CIO of the VA, there was the governing committee on this thing, stepped back and said, you know, if we're after this semantic harmonization right now, the way we're doing this, it'll be another decade and a half before we exchange any information. So you know what? We're just going to send text blobs to each other. Well, because of that decision, we have sent millions of text blobs back and forth to each other. Now, admittedly, when a doctor gets them, it's kind of like getting an electronic telephone book delivered to you without much of an index. But nonetheless, if they had made that decision and they had persevered on that very high degree of syntax and semantic harmonization, we wouldn't have been sharing information yet. And yet millions have, so they just said, send the blobs. For the time being, let the healthcare providers do what they can do with them. So, and that's FHIE, and millions of records have gone back and forth that way. And with BHIE, this is a similar story. Cheddar still, the machine readable thing, Cheddar is still pretty much limited to drugs and allergies, and it's still very small. It is machine readable, both ends, et cetera, but it's still basically the same functionality. It's been there for probably 10 years, and we haven't advanced that beyond what it was. So that would be that example. With Vista Evolution, there is I'm going to call them a change management group. That's probably the wrong name. But Gail Graham, Terry Cullen, Linda Wiedemeyer, Muriel Bean, and probably a few names I'm leaving out, is the VHA group that shepherded the birth of those KPIs. They are now going through and create the metrics program, and it will be them who have to create the change management program to make all those policy and procedural changes in VHA necessary to take advantage of what Vista Evolution offers. To create what I showed you for VBA for the claims, that group will have to do that kind of thinking for healthcare delivery. So you have the Vista Evolution features in the middle, the old processes on the left, the new processes on the right, and then a whole bunch of change management activity to get people to behave that way. It's that group in VHA that would be doing it.
So I'm going to cut off questions here. We do have a panel discussion, and Dr. Tibbits will be part of that panel a bit later in the afternoon. So join me in thanking. And thank you, Philip, for yielding a little bit of time to let us do that. So next.